so much, Elizabeth, and thank you for the more than adequate preparation that you facilitated, Elizabeth. And of course, Julie and I, in great diligence, had our slides ready nice and early, had rehearsed and had gone through all of our GoToMeeting and GoToWebinar technology to make sure that it was working well, and here we are. So many apologies, but I am very grateful. We are very grateful for all attending today, and I'm going to jump right into it. This was a great opportunity for both Julie and I to speak to the palliative in the stroke best practice guideline. And it's a very impressive accomplishment that's been achieved with these recommendations. And we really wanted to highlight and point out some of the more practical, useful elements that would really improve the palliative care experience of people who have strokes in their family. So stroke does remain the third leading cause of death in our country, and there is fairly clear evidence that outlines that we've got a ways to go in terms of meeting the needs of stroke patients who are at the end of their life. Julie, if you wouldn't mind just muting your mic. The evidence around unmet needs may come as a surprise to some, but it actually is less so about symptom control and more so about the families feeling like they're being involved in decision making, patients and families being told when death is imminent, and then respecting a person's dignity. These are the three things that stroke patients tell us could most improve in terms of meeting their needs at the end of life. So what I thought was really interesting and what I haven't seen many groups do before is actually take things to the point of indicators, of identifying some indicators that would tell us be measures of palliative and end-of-life care. And I want to point out at the very beginning here that very appropriately and very relieving for me, hand in hand with palliative care was advanced care planning within this recommendation set. In fact, the first three indicators for the advanced care planning element and the palliative care and end-of-life care element were exactly the same. And so this was really quite, I found this very encouraging because I think specifically for this population, advanced care planning goes hand in hand with effective palliative care. And what I would say of these three indicators that are the first three in both indicator sets, the most important and the most aligned with what we know about advanced care planning and palliative care in this population would be for stroke patients to identify a substitute decision maker. And my aim over the next sort of 15 minutes is to explain why I would rank this as the most important indicator for both. So to take a step back a little bit, I want to make sure that we're all on the same page and have a shared understanding of what is meant by the phrase palliative care, because it has gone through a tremendous evolution over the last several years, and in particular the last few years. No longer are we equating palliative care with end-of-life care. Now, this might be the case for patients and families and many of our colleagues that we associate palliative care with end-of-life care, but there's clear evidence in multiple populations that palliative care has relevance and can have the greatest impact from the time of diagnosis of life-limiting illness or disease into long after death, into caregiver bereavement. So we're really thinking of palliative care as something that is to be integrated from the time of diagnosis into long after end-of-life care, with end-of-life care being a component of palliative care. Even this perspective, though, is now outdated. Because if you think about it, the palliative care that would need to be provided to an entire population of folks that have life-limiting illness, and in that I would include congestive heart failure, COPD, metastatic cancer, all of the neurodegenerative disorders, and I would put a group of stroke patients within that category as well. That's a tremendous amount of palliative care that needs to be provided, and that currently actually is being provided, but it does make this perspective on what palliative care is a bit outdated. So let's try and unpack this a little bit further. What do we know about, what evidence do we have on the impact of palliative care? I made reference to impact occurring from the time of diagnosis. What we know when palliative care is provided to patients and their families, that there's a reduced symptom burden in patients, there's less anxiety and depression in both family members and patients. There's less caregiver distress and trauma, and I'm going to come back to this point in a moment, but better quality of life, less aggressive treatments, fewer unwanted tests and investigations, fewer admissions, overall lower healthcare costs. And what I did not include on this list is for the potential for many groups to actually live longer. So in some populations, many populations actually, there's clear evidence that palliative care provided from the time of diagnosis of serious illness actually lengthens survival for patients. It doesn't result in a hastening of their death, most certainly, but in fact people live longer. This is one study that demonstrates straight to this, and this was a study of patients who had metastatic cancer at the time of diagnosis and provided as an intervention palliative care in the outpatient setting. Comparing oncology patients in this population who had usual oncology care, which may have involved palliative care, those that had palliative care from diagnosis had a better understanding of their illness, had fewer treatments that were not aligned with their values and goals at the end of their life, and in fact they actually lived longer than those who didn't have palliative care at the time of diagnosis. What's even more impressive about this particular study is that the length of survival benefit was greater for palliative care than it is for Tarceva, which is an anti-chemotherapy agent. And what this is meant to reflect is just really dispel the myths that palliative care is only for end of life and actually may hasten a person's death, when in fact people do actually live longer. And I would say that's the case likely to be the case for the stroke population as well. Every study to date really does show significant value of palliative care, particularly from the time of diagnosis. And what this slide does is try to be a more contemporary or up-to-date version of how we're thinking about palliative care, in that from a person's perspective, from a patient's perspective, they're going to have a complexity of needs. So from the initial slide around unmet needs within the stroke population, there's going to be a complexity for each person around those needs. Complexity of illness understanding, complexity of involving families in decision-making around strokes, and complexity of a person maintaining dignity. May be very straightforward and basic for some patients, and that might be a very complex need to meet in others. And the role of specialty palliative care is really when the complexity of meeting those needs reaches a certain point. And the role that's currently played by many teams, like stroke teams, is to provide palliative care when the needs are a bit more basic. And so what this is really trying to do is outline that palliative care from the point of diagnosis through illness progression into end stage, and that the majority of palliative care is likely going to need to be provided by the existing teams that currently actually are already providing great palliative care to folks. So if we look at the actual stroke best practice recommendations, what are the concrete ways that we can improve this experience for people? And the two that popped out for me as impacting direct care were the integration of a palliative care approach. So for patients when stroke is quite catastrophic, or if there's significant comorbidity that pre-exists, is really thinking about a palliative approach to care, or integrating the basic set of palliative care related skills that likely teams are already providing. And then a very, maybe perhaps straightforward, but this is what matters to patients and families, is regular communication to kind of assess if needs are being met and ensure that they are. In terms of process, what are the process things that could be done differently to improve the experience of stroke patients in and around end of life? It would be ensuring that there is a process in place to refer to specialist palliative care for when needs become complex. What I thought was fantastic was the specific recommendation around a referral process to spiritual care services. This is quite reassuring to me as well, because this is quite evidence-based. What's most important to people when they are confronted with the possibility of their own mortality is a certain, I won't say faith or religion, but a certain existential or spiritual needs that become relevant in the moment, and we may need to access our spiritual care colleagues to support this process. Communication training reflects number 2 above, in that it's difficult to have conversations with patients about poor prognosis. And then another really important concrete way that could improve the experience is to think about integrating some of the pathways or protocols that do effectively manage symptoms and trigger some of the things like spiritual care referral and nutrition referral as examples. So I thought these were fantastic recommendations that are taken directly from the best practice piece of work that I wanted to underscore and really highlight as what I would consider to be important for every stroke program in Canada to be thinking about. So when I looked at the advanced care planning recommendations with the stroke best practice, there were a few that stuck out for me that I wanted to highlight and wanted to maybe challenge the group today a little bit around how they're thinking about advanced care planning in general. So these are 3 direct quotes from the recommendations. And what these 3 quotes sort of outline are some of the definitions around advanced care planning and some of the outcomes. What I really wanted to highlight was this second point, which outlines that often patients with stroke, the direction of decisions is unclear for the family when the patient is unable to participate in decision making. So this statement is exceptionally important. And what I wanted to do was take a few minutes and outline why the direction of decisions is often unclear for the family and what can be done to make it a little bit more clear. So we know that if there is effective advanced care planning, that all of those outcomes that are true of palliative care are also true for advanced care planning. So if we're effective with how we are advanced care planning with patients, then we will have all of these same outcomes. But this was not always the case. What has changed to have made advanced care planning effective? And I come back to the advanced care planning recommendations in the stroke best practice, and this particular recommendation around advanced care planning being a discussion of a patient's preference around the medical appropriateness of these therapies. And what I want to challenge folks to think about is that for many patients, this approach might not be the most effective route to decision making, and it might seem counterintuitive, but a person's preference around medical appropriateness for these therapies might actually not be the most effective way to decision making. And let me explain why. A bit too far. So when we think of advanced care planning, often broad statements are made. Most of the time, however, these broad statements do not help guide decision making. And I'm going to give you some examples in a moment. But if we think about this list of treatments, a person having preferences around these kinds of treatments is less likely if they don't have a context from which to have preferences. So a preference around cardiopulmonary resuscitation may be informed by what they see on TV, what they hear, may be informed by all kinds of misinformation. There's pretty clear data now that what actually matters to a person is not whether or not they want these treatments or have a preference for these treatments. It's the outcome of these treatments that a person is able to have opinion and preferences for. So not the treatments themselves, but the outcomes of these treatments is what a person values. So for some, the outcome of loss of physical independence is not acceptable or not tolerable. For others, the outcome of loss of mental independence or cognitive ability is not acceptable or not tolerable. And what advanced care planning really needs to be is to tease some of these elements of acceptability and intolerability out. When a broad statement is made, and I'll show you examples with this slide, the next question is why. So here's some examples. Commonly used phrases with advanced care planning are no heroics, no machines, no tubes, and do everything. This is certainly true for the population of stroke patients that I've cared for. But if you think about it for a moment, when it comes to no heroics and no machines, is that ever? Or is that only when there's no chance of recovery? What if there was a 90% chance of recovery? And if we think more about no tubes, what if the circumstances were short-term and reversible? Would a tube be acceptable? So a person who's come to have this sort of broad statement or broad perspective, we can see pretty quickly that a few elements of the story populating a few elements, populating the story with a few elements, and it becomes very tricky to apply these kinds of broad statements to actual decision making. Do everything is another example. What does this mean? What state of being is aimed to be achieved by the person, which is going to vary based on the level of their health decline or their function? How will a substitute decision maker know when everything has been done? That, I think, is a critically important question. So when we hear broad statements, what's more helpful to substitute decision makers when it comes time to decision making is what it is that's brought a person to believe this about machines or heroics. So what is it about heroics or machines that makes a person say, I don't want that? Is it actually that they don't want the physical incapacity or the mental incapacity that they associate with it? Do they have misinformation about what heroics and machines actually means? What is it about a tube? What have they seen? What have they experienced about a tube that makes them not want a tube? And then the other perspective is what would it, when a patient says, I want everything done, for me, that's kind of exciting because then I get to understand why, where that comes from. What does it mean to the person if we weren't to do everything? What worries or fears come to mind? And how should we approach reconciling this? Because at some point, a substitute decision maker is going to need to know when everything has been done. So how do we tease this out into something that's relatable and practical in the clinical decision-making context? And the way to do this, I think, is to think about how a person actually makes healthcare decisions, because there's two parts to this equation. There's the left hand, or the values and goals part, and that's really of the person, what's important to them, and as I mentioned, more importantly, why it's important to them. And then the right side of the equation is information and evidence about the disease, about treatments. And so for decision making to be effective, both parts, both elements need to be contributing to the actual decision making process. So how are we doing with this? So in terms of values and goals, a person can really only reflect on their goals their values based on the information that they have about their current context. And the challenge is that the vast majority of people who have serious illness do not fully appreciate the life-limiting or incurable nature of these illnesses. So specifically, in people with congestive heart failure, 2/3 of them don't actually believe that it will shorten their life. 70% of people on dialysis believe that dialysis is healing or, in fact, curing their kidneys. And 3/4 of folks that have cancer do not appreciate that the chemotherapy that they're receiving is not intended to cure them. So what that means for decision making is that when considering values, how a person feels about their life and about their health, 3/4 of them are basing this on inaccurate information, an accurate understanding of their underlying illness. So we're not doing so great in terms of the values and the goals piece. In terms of the information and evidence piece, this comes back to I would say, outdated perspective around advanced care planning, because in the past we thought that the purpose was to be about making advanced decisions or decisions about treatments at the end of life. There's very clear evidence that advanced directives have little to no impact on the outcomes, so they do not impact the care that a person actually receives. And I would propose that the reason why this is now outdated is because of the fundamental flaw in that we've taken the person out of the equation with this. For most of Canada, the phrase advanced directives now has a really quite limited role. In Ontario, as an example, it is not a recognized legal entity. So advanced care directives, the legal framework across Canada, is starting to catch up with the clinical evidence that we have around them not being effective. So what do we actually do then in advanced care planning? Well, we need to come back to the purpose, and that is to rethink advanced care planning a little bit, because the person really is to prepare substitute decision makers for decision making with the right information that would guide decision making in the future if the person loses capacity. The way to do that is to ensure that a person's values are known, improve the understanding of both the patient and the SDM of the illness, and engage those SDM in the discussions. And only then will we truly actually be effective in our advanced care planning. So just in the last couple of minutes before I'll turn it over to Julie, this is something that I've been talking about for quite some time, and this is reinforced by a study that was just released several weeks ago, where we were finally able to achieve in Canada globally consensus on a definition of what advanced care planning actually is, the components and the outcome. And I just want to highlight that this group of international experts have came to an agreement finally that the purpose is to elicit values and personal life goals, which then would guide future treatment recommendations or decisions. And that during these conversations, getting this information is really about this information being translated by clinicians and substitute decision makers into more specific discussions concerning treatments over time in the future. So to summarize then, the core components of advanced care planning, what we need to be thinking about is this the right SDM? We need to ask the patients, is this the right person for you to be making decisions? If not, who is? And complete the appropriate documentation for your province. And then the next step is to make sure that we prepare SDMs by communicating the wishes and values that would help guide healthcare decision-making over time. This is an example of a substitute decision-maker hierarchy that we have in Ontario that really outlines that every person actually already has a substitute decision-maker, and it is about confirming that this is the right person. Because if it's not, then an attorney for personal care can be completed. Just to give you some concrete in my last slide or two, what then are the conversations that do need to happen during advanced care planning? These are the actual questions that would give substitute decision makers the helpful information. It is what a person understands about their illness and what information would be helpful or important, what they value, what in life, what gives it meaning, what if a person is critically ill or if they're at the end of their life, what worries or fears come to mind. What would you be willing to trade for the chance of more of what's important to you? And then if you were near the end of your life, what would make this more meaningful? This is just a framework that I'm not going to spend too much time on, but goals of care discussions were also referred to in the recommendations a number of times. And I just wanted to introduce the concept and idea of a distinction between advanced care planning, goals of care discussion, and decision-making as distinct elements of a person-centered decision-making continuum. So there's more to learn about these concepts, but what this is saying is that really we need to be focusing on a person for advanced care planning, that person or their SDM for decision making, and ensure that we start with what a person has as goals for their own care when we are making decisions, when it comes time to make decisions over time. Just some language around this, around these three components of person-centered decision-making. And the thing to point out, I think, in this is the outcomes for advanced care planning. I've already talked about being SDMs are confirmed and prepared with the information that will guide decision-making. Goals of care discussions, the outcome of that would be a person understands their illness and the team understands that person's values and goals such that decision-making can then be pursued. So the three pearls that I would leave you all with in terms of how can you concretely move things forward in wherever you are is to partner with your local palliative care team, establish a model of care, and be sure to think about how you're going to measure the impact. Think about the potential outcomes of treatments as being more likely to matter to a patient than treatments themselves. And it is about getting to an understanding about those outcomes that will allow us to facilitate decision-making about specific treatments. And that standardized person-centered advanced care planning is possible. And the resource that I put up just a few slides ago is available in the repository best practices on speakupontario.ca. So I will hand it over to Julie.
Thank you very much, Dr. Myers. That was a great presentation.
My pleasure.
I would encourage anyone to send their questions now to the chat function through GoToWebinar so we can address those when Julie's presentation has concluded.
Hi everyone. As you can see, that the technology is not my forte, but certainly connecting with individuals at end of life is. So that's what we're really here to talk about. I will just start with see if I can forward the slides. Okay, so the slide that I skipped was just to say that I don't have any conflict of interest. But and I started to say earlier, just you know, having these conversations and providing these interventions are important, and that that my experience has taught me this. So in order to be able to provide a palliative approach, we really need to know, practically speaking, what it is in order to be able to use it. And we need to be able to be aware of practical ways that we can engage in these important conversations that Dr. Myers has just been talking about, and to determine the needs of the stroke patient that we're working with that requires a palliative approach. But we also have to have knowledge about what we can do with these with our patients in order to optimize the care and bring comfort and quality of life to them. So stroke best practice is recommending to all of us that you know, Dr. Myers had talked in some detail about some of the other like medically focused areas. I wanted to focus on what I felt was important from my perspective as another member of the interprofessional team. So we're going to be, for the rest of the presentation, looking at the palliative approach, optimizing care, the interprofessional team, appropriate communication skills and knowledge, addressing physical, spiritual, psychosocial, and social needs of patients and families and informal caregivers, and regular communication to ensure that people's potentially changing needs are met. So in order to be able to provide this approach, you know, we need to know a little bit more about it. And this definition, obviously, there's a lot of words on the screen, but the rest of the presentation, I really wanted to focus on the highlighted words: autonomy, active involvement, control, quality of life, open and sensitive communication, advanced care planning, psychosocial and spiritual support, and regular opportunities to review the plan and goals of care. So having knowledge of this matters because of individuals like Jim. In my experience, a palliative approach brings connection, compassion, respect, and dignity. It supports seeing a person beyond their condition as a whole person, including body, mind, and spirit, essentially seeing them as a human being. In Jim's case, using a palliative approach added life. I was working with Jim in the inpatient rehabilitation unit, and he's young, age 59, and had a significant hemorrhagic stroke, and that left him globally impaired. Communication was a challenge to him because he had severe aphasia and apraxia, and he was progressing well in his rehabilitation and really determined to restore his independence. The team received news from his spouse that his mother had died, and he was not yet aware. His spouse was afraid that telling him would actually affect his progress. She was encouraged to share the news with Jim from the team, and I clearly remember him coming into the therapy room after he had received the news. My approach couldn't be to ignore the reality that he was clearly grieving and devastated. So despite his stroke, his aphasia, his cognitive and perceptual deficits, this man clearly had the capacity to feel. I acknowledged the situation and offered him support, and then the tears came. It was at this time I made a deeper connection with him. I provided him with a space to express his grief in the quiet therapy room, being mindful that this session had to be about him and his needs and not on my own agenda. We came back to the breathing strategies that he had learned in previous sessions to cope with the challenges he was facing post-stroke. I gave him choices, asking him how would he like to proceed. I was empowering him to connect to what mattered to him in that moment. He wanted to proceed with the session, so we focused on the psychosocial needs to ground and relax him through doing a body scan. This activity connected him to his body, to his mind, and his spirit. So Jim appreciated in the session that I cared and that his situation mattered. He also appreciated that he had tools, despite the extent of his disability, to cope with his experience. At the same time, Jim was facing having an undiagnosed lesion in his lung, and shortly after receiving the news of his mother's death, a hospitalist met with Jim and his spouse to discuss with them that the lesion was malignant. And the prognosis was poor, and he would benefit from receiving a palliative approach. I asked the hospitalist how the conversation went and described how I was engaging in a palliative approach and how I had integrated compassion into Jim's care, given the circumstances. I determined that Jim wanted to return home as soon as possible, and I did everything I knew possible to make this a smooth and seamless transition. I think what really mattered in this story was that Jim knew I cared. We had ongoing and open, sensitive communication that made it possible for me, in the context of the moment, to support his changing needs. I supported his whole person needs, not just the physically focused, task-orientated needs that we are much more comfortable to provide. Because of Jim, I was invited to join the hospital palliative care team. Jim's hospitalist was the head of the team, and in our discussion about Jim, he promptly invited me. So situations similar to Jim's arise regularly, and you could be the person that's providing care. So how do we care for ourselves when we're making this shift to providing a client-centered holistic approach? So I want you to take a moment to imagine a scenario when you are working with someone like Jim, a person that you knew was going to die. Like, how are you feeling? And then take another moment just to process what comes to mind when you think about what you're going to say and what you can do. So these are thoughts of third-year medical students when they were asked how they felt about their first patient death, and some hadn't experienced death. Notice that some of these words are actually positive. So feeling overwhelmed, inexperienced, and uneasy may provoke anxiety and fear within us. And I wanted to share a couple of strategies that I use that I find extremely powerful and helpful. So the first one is grounding, so just simply feeling your feet. So what it does is it brings attention to your body, and you can stabilize your mind through this process. It's called embodiment. And another way that we can do this is using our breath, and I use a simple breathing technique. And I teach it to patients, to families, and I use it myself. And you put the tongue on the roof of your mouth behind your teeth. You breathe in for 3 and hold for 1, breathe out for 3 and hold for 1, and you repeat that 3 times. So just I wanted to say that, you know, these things are simple, but they are powerful, and they center us and they calm our central nervous system. So a couple of tips. Don't allow your discomfort to distance you from the patient. The discomfort we are feeling is a way to connect with them, because it's death and dying is a common fear. It's a shared human experience, and actually being uncomfortable is okay. And don't take it personally. Recognize that the situation isn't about you, and often end-of-life situations are very emotionally charged, and what's happening is painful. It's fear-driven, and we just don't know what to expect. So consider perhaps that the anger that may be present is coming from an expression of pain and fear. And challenging circumstances aren't always bad. I mean, we may label them as bad, but they are actually an opportunity to learn. And also to expect the unexpected. Each situation will be different, and it's actually a very, very fluid area of practice. So what are some of the things that we can ask our patients? These are key phrases, but what I would suggest is that you figure out something that would be comfortable for you. I use the how are you feeling within yourself a lot. I mean, I ask every single patient. And I was working with a physio one time that was providing coverage on the rehab unit, and he said that this question would change his practice forever. He appreciated it was that powerful that it, because we were opening up, like its ability, you know, the way it opened up sensitive communication with a patient and family who were actually suffering and struggling to cope following the reality of a devastating stroke. Just a tip to listen, to stop. We do have a tendency to take over. Allow space for silence and meet a person where they're at. And if they don't want to talk, then that's okay too. And continue the conversation, because dying is a process. It's a time of constant change. So keep checking in. Has the focus changed? Have the goals changed? So Jeff has informed us greatly about advanced care planning and the importance of speaking up and having those conversations. So this, I just wanted to share with you Canada's National Advanced Care Planning Initiative, and this is their logo, and really it reflects what Jeff was saying about is the wishes, it's about conversations, and it's about how people care for each other. And I just wanted to say that I actually, there's so many resources that this links to, and I shared the interactive workbook that they have with this young stroke patient. Her spouse had died a few years earlier, and she was scared about the uncertainty of the future, and she knew the possibility of what could happen because she'd had a devastating stroke. So she was asking me for information, and it's important that we're aware that when those opportunities present themselves, that we start these conversations early in the illness trajectory. So just, you know, just at the end here, like, just what can we do? Just be mindful that there is nothing to fix or change. Like, we're always wanting to do something, but I think more importantly, it's making a connection and showing a person that you care or that they matter. Staying present and focusing your attention on that person or the situation, just taking a few minutes to be with them. I know we always have a very fast pace, but it does actually not need to take a lot of our time, and often what is meaningful takes place in a moment. So, and I also think it's very powerful to acknowledge and thank an individual for sharing their vulnerability with you. So to be sensitive, compassionate, consistent, and consider, you know, what does it mean to be deeply kind? And what would serve the individual's needs best in the situation? Pay attention, notice what the needs are, and expect changes to happen. Provide care in the context of the moment, and when the needs are evident or being expressed, and consider that an unmet need may not be able to wait until a referral is processed to a palliative team. So focus on what matters to the patient. For many, it will, it's always going to look different. You know, for some it's independence, to return home safely, to do an activity that's meaningful, to share stories, or maybe to create legacies. Just around judgment, it's not about us. The situation is not personal. Include families and loved ones, empower them. And I added here after death care. I do have experience with this, and I had a story with young children washing their father's hands and feet, like sharing stories and tears with him. But for them, it was the beginning of healthy grieving. Any connection to nature, anything that's possible in, you know, and it's maybe challenging in a clinical setting. Also, I just wanted to mention non-medical therapies. At Holland Healthcare, we're in the process of developing a new program and developing evidence to determine the benefits of Reiki provided by volunteers to patients and families at end of life. So these sorts of things are new, and it's sort of changing the approach that we're taking. Use the team, so important. Connect with other members. Everybody has something to bring to palliative care. Be aware of resources, and I have included a list in the last slide that you can access of very helpful resources to find out more. And I just wanted to mention debriefing. It's so important to acknowledge and process our challenging circumstances. And just at the end, like self-care, when do we consider taking care of ourselves? So just take a moment, because it's really important. So just to take away, potentially we all may be caring for an individual that is dying after having a stroke. And healthcare providers in primary care can provide a palliative approach to care. And there is need for more education, research, and to keep the conversation going about what needs to happen for all stroke patients in need to receive a palliative care approach. So I'm going to just forward to the slide with resources and then say thank you very much and pass it back to Elizabeth.
Thanks very much for Julie's presentation and for all your insight and resources. I do recognize that we only have a few minutes left for questions, but we can go a little bit past 2 if people have time. Our speakers are willing to stay a little bit longer, recognizing that we did start late, so we can have a Q&A if people do have questions. So again, I encourage you to send your questions in question box to webinar, and we do have some questions that have come up already, and I will get to those in just a minute. So the first question here is even, and I think, Jeff, are you on the line?
I am, yes.
Okay, great. I think that this may be directed at your presentation. Even after adequate discussion, how do you recommend dealing with unreasonable requests for additional care from patients?
So that's a great question, and I think it comes back to the approach of understanding why. So treatments, and the more that we focus on actual decisions, the less likely we are to get to decision making, I would say in general. And so if we seek to understand a person's perspective on why they are hanging on to what we would view as unreasonable expectations, that really gets us at the root of how to make the decision. So that's what I would say, just as it's always easier when there's a specific case, but I would say it's getting at the root of why a person has a specific perspective, what their worries or fears are if we were to do the opposite approach, and what the underlying value is driving the actual decision.
Great, thanks. And just another question as well. How do you suggest we deal with requests for made for stroke patients about imminently foreseeable demise?
So that's a really good question. So it's just for folks to appreciate, it's medical assistance in dying, or the physician-assisted dying, or clinician-assisted dying in Canada that's now legal. And I would say that if I understand the question correctly, how do we deal with requests that come in for stroke patients? And the approach really should be the same, the approach that's taken for any patient, is to first of all ensure that there is capacity to be having even a conversation about this. And it really is beginning with what a person is actually asking for when MAID or medical assistance in dying is raised. You know, there is, clinicians can, nurse practitioners and physicians can conscientiously object to performing the procedure, but what I would say we all have a duty to do is explore an underlying request, because it may not be that that's in fact what a person is requesting. It may be that they are expressing existential distress, and the only language that they have around that is by making a request for MAID. So I would encourage folks not to react strongly to a person who's making an inquiry about MAID, and really again seek to understand what is underlying that request.
Okay, great. Thanks very much. The next question may be directed at both Julie and Dr. Myers, so I'm just going to read it out. It's a little bit of a lengthy one. In hemorrhagic stroke, a big stroke can show significant recovery if good medical treatment occurs during the first 48 hours. Thus, these patients should not be made palliative during this time. However, this may not be occurring due to values of the family and beliefs of the staff regarding recovery. Do you have any thoughts, suggestions regarding this kind of situation? They may appear very poor and require feeding tubes, etc., but if good medical care occurs in the first couple of days, those patients who can recover have the opportunity to.
Maybe I'll start and then I'll turn it over to Julie for her perspective. So the first thing I would say about that scenario is that whole idea of somebody becoming palliative. I understand what the question is asking and what the person is, but it really is are we shifting to end-of-life care or are we not? As opposed to, is the person palliative or not? And I know it sounds like semantics, but it really isn't, because if we're providing, if we can't discern at the time of hemorrhagic stroke who it is that will have the kinds of outcomes that we're aiming to with treatment, then it seems to me that we would be presenting the scenario to a decision maker in a way that is reflective of the evidence around the chance or the likelihood of improvement. So the likelihood of the outcomes are what people sort of relate to. So if it's a 1% chance that the person after 48 hours is going to have great outcomes versus a 90% chance, I think that would be very different in terms of the decision-making process. So I think it's coming at it from what's the best evidence that we have for the likelihood of outcomes, and it's constantly reassessing this with the family and understanding what the underlying person values so that the decisions can be aligned with those values as this evolves over time. None of us have a crystal ball, right? And that's the challenge with these conversations. But it seems to me that we would be wanting to advocate for the best best medical treatments that have a high likelihood of the outcomes that we would aim for, but really putting it back in the hands of our decision makers and patients, and coming at it from a perspective of what they value. Julie, did you have other thoughts?
Just to say that, you know, in that kind of situation, I mean, you would want to engage in palliative approach anyway, because they do have a condition that is potentially life-limiting. So, you know, but the focus of the approach is on you know, making life the best that it can be in those circumstances. And if you're addressing all of the needs that are presented, and you're looking at that psychosocial piece and the needs of the family, the significant others, you know, then you're allowing those conversations to take place.
It's a really great point, Julie. And you know, what you're reinforcing for me is the importance of not considering palliative care as an either or, right? Mm-hmm. Where palliative care is not something that you would, that some magically clear and luminant moment that we'll know when a person becomes palliative. That is probably the greatest barrier to providing effective palliative care. So it really is, yes, there are some components of end-of-life care that are very different than or symptom-focused care that are very different than curative or remiss type approaches. But focusing on throughout the illness trajectory, the psychosocial physical needs that a person has is really the important approach to adopt.
And just to address the few questions, thank you very much, sorry, just to address the few questions that have come in regarding a slide deck and recording. So the recording will be available on the Stroke Best Practice website, as well as sent out through the follow-up email that will include a link to a survey. We do not make the presentation slides available, so no, we won't be able to share those with everyone. I have put the resource slide back up that was included in Julie's presentation, so hopefully that's useful. And then I just have a few more questions, and we'll wrap up in about 5 minutes or so. So on to the next question here. Does anyone have a catastrophic stroke order set, and is this something that would be supported?
Oh, that's a great question. I've actually not seen one myself, and I'm wondering if the question is an end-of-life order set, or what the unique elements of a catastrophic stroke care of a person with catastrophic stroke, I guess, prior to clarity around it being end of life. Julie, I'm not aware of any. I think it's a fantastic idea. Julie, I wonder if you know of any.
No, I'm sorry, I haven't heard of any either.
You know, throughout the stroke best practice guideline in the palliative care, there are several mentions of specific pathways or end-of-life pathways. And I don't, like I said, I'm sorry, I don't know if there might be something, elements of a pathway that would be unique in the setting of catastrophic stroke. But that certainly would be fill a gap if there is, and if there isn't such a tool currently available. I would think that on the stroke best practice website there would be some linkages there, and I can try and check that out afterwards anyways. Elizabeth, that would help.
Yeah, that would be great. We can connect for sure regarding that. Thank you for the question. And then the next question here, how do you encourage doctors to have that frank discussion with the patient regarding prognosis so that we can start the values discussion and move towards the palliative approach?
So I've got my webcam off, but you would see a massive smile on my face, because if I had the answer to that question, I would be a very, very rich person. You know, a great majority of my time and reflection on this over the last couple of years has been towards thinking about physician behavior, and I would say that the right response to that question is actually to stop thinking about physician behavior. I hear what the question is around prognosis, but what matters to a person in terms of information around their illness is so completely unique. And I do think that there are such amazingly skilled clinicians on interprofessional teams who are not being maximally utilized when it comes down to the communication around some of these difficult conversations. I do think that there are communication skill development training programs and courses that are available, but a person needs to want to improve their skills. And those folks that want to improve their communication skills tend not to be the ones that need to improve their communication skills, to be honest. So the answer to the question is this, is that, number one, I do think that it's thinking about the other members of the team who could fill in some of the communication skill gaps. Number two, thinking a bit more broadly about the word prognosis and understanding that prognosis is more than just how long a person has left to live, but is what is the expected outcome. And when you frame it in that term, in that way, what's the expected outcome? What can a person imagine? What can a person picture? Then you can, and getting a person, to the extent possible, having a person really, really flesh out what they understand about their illness, and so that we can say yes or no. No, that's not what you can expect. Then we'll actually be better, I think, at communication around what to expect in the future. Julie, do you have thoughts on that?
The only thing that really comes to mind is, like, you know, just sort of for the future, and I know I teach medical students, and they're always asking these questions, and you know, that they really value having experience, like experiential education. They talk on my first death, and just having those conversations in a safe and non-threatening environment, so that you can actually you know, sort of connect to that, and what might that look like, and how might you feel, and you know. So I think that, you know, it would be great if there was more education in school about that for all interprofessionals, like and it is an interprofessional education session, so kind of you're in it together.
The helpful tip that I would give for any physicians that are participating, or those that can influence physicians, is if you're having a conversation, a prognosis conversation, it is not about information giving. It is, as much as possible, information retrieving. So if you're having a conversation, it is being relentless around what a person understands, what they imagine, what they expect to happen in the future, what they're, if a clinician is presented with a patient who says, how long do I have left to live, or what can I expect in the future, the response to that is, what's your gut tell you? I have, in 15 years of practice, I've actually never responded to that question with anything but another set of questions. And so to the extent possible is pulling as much information that we can from patients and families and building on that. That I would say is the most helpful communication tip that I could give in a moment.
Mm-hmm. And also just having the courage to go there, and it's like the person actually leads the discussion themselves, or like they sort of guide the intervention themselves, because you're just really listening and you're just present to what it is that they're saying and processing at that time.
Absolutely, Julie, and it's difficult for people to wrap their head around that, but truly, when we're presented with these difficult conversations, it's usually because we assume that there's the right information to be given in the right way, and I would say to flip that and really say no, it's about getting as much information as possible from the person and their family. People have tons of information. It may be inaccurate, but they have tons of information, and it's really pulling it out of them already.
Okay, and the last question, thanks very much, is a newer concept in the UK are supportive care teams for those with life-limiting illnesses, which is not meant to be synonymous with palliative care teams. Have you heard of this approach, and do you think it would be wise to incorporate that terminology for those with a life-limiting illness?
So yes, I am familiar with the term, and when you define palliative care as care that is relevant and that augments and is an additional layer of support to disease-focused care from the time of diagnosis until long after end of life, it's hard for me to conceptualize the different approach that might be used by supportive care teams, with the exception of complete integration, right? So, for example, if there was a supportive care stroke team for patients with stroke that have life-limiting illness or life-limiting stroke, it would be that supportive care team would have both neurological and stroke experience and training, as well as palliative care experience and training. The phrase supportive care has surfaced in many contexts because of clinicians' discomfort with the phrase palliative care, to be perfectly frank. So I've gotten many requests to change the name of my clinic to supportive care clinic, and I don't know that that's the answer. I think the answer is actually education around what palliative care is, which is what I think we've attempted to do today. I do think that the supportive care teams may fill a gap when there is no reconciling the term of palliative care. But I do appreciate the distinction, but I question the underlying rationale.
Okay, great. So that concludes our Q&A. Thank you again to our speakers, Dr. Myers and Julie, for their excellent presentations and that excellent and very informative Q&A. A lot of good questions and a lot of engagement on this topic. We will be sending you the recording and a survey, as mentioned, and we look forward to future webinars and to hearing your feedback so we can continue delivering these learning events. So thank you, everyone, for joining, and we hope you have a great afternoon. Thanks, everyone.
Thanks so much.
Thank you.